Our next speaker hails from Dr. Eichler's lab. That is Natalie Grant, Women's Studies in ALD. So Natalie.
Good morning, everyone. So I'm so excited to be here today and talk about this extremely important topic, which is adult women with adrenoleukodystrophy. So today I'm going to give an overview of the symptoms that are common in women with ALD, give a background on some research studies in the past, some current and upcoming research efforts as well, and highlight unmet needs and knowledge gaps. So I wanted to start out by giving an overview of some of the larger studies that have been done in women with ALD. So we've known for about 40 years now that women with ALD do develop symptoms. However, it wasn't until the past 10 or so years that we realized how prevalent these symptoms are. So through the years, we've come to understand that a large proportion of women with ALD are symptomatic and that symptoms become more prominent as women age. I just wanted to share one of the figures that the group in Amsterdam published back in 2014. I think this is a great representation of how symptom burden increases with age. And this figure shows how only 18% of women in their cohort between the ages of 20 and 40 had symptoms, and how this percentage rise dramatically to 81% after 40 years of age. I next want to highlight some of the common symptoms seen in women with ALD beyond gait and balance difficulties. So this was an important study led by Camille Kaur at Mass General with the guidance of urologist Pablo Gomery, and it was focused on characterizing urinary and bowel symptoms in patients with ALD. We found that symptoms are quite comparable between men and women with ALD. However, women in this cohort were approximately 10 years older than the men. And in this cohort, just under 85% of women experience at least one urinary or bowel symptom, most commonly urinary urgency, incontinence, and fecal urgency. This study also highlighted how detrimental these symptoms are to one's quality of life. So in a survey that was completed by a subset of these patients, we found that over a third of patients reported a moderate to severe impact on quality of life. And one of the pretty shocking findings was the result of a question asking about the warning time from the first sensation of urgency to the point that incontinence is inevitable. And we found that patients reported average warning times between 3 and 4 minutes for fecal and urinary urgency. So with the co-occurrence of gait and balance impairments in this population, it's likely that these patients are even more affected by these symptoms. Another topic that we've been focusing on at MGH is movement disorders. So we've studied this through literature review, through retrospective chart review, and through prospective evaluation in collaboration with our movement disorders experts at Mass General. And recently we've observed that women are more frequently affected by movement disorders, but independent of the demyelinating brain disease seen in the men. It's still an evolving topic that we're still learning about. Here are some of the results from the retrospective chart review. So the most common movement disorder was ataxia. However, other common things we see in the women are tremors, so both in the hands and arms as well as in the head, which is called head titubation. Also cervical dystonia, which is involuntary head or neck tilt, which is shown in the photo on the right, and also speech abnormalities, specifically spasmodic dysphonia or voice tremor. Another movement disorder we commonly see in ALD is restless leg syndrome. RLS is characterized by the 4 diagnostic criteria listed on the bottom left. So it's an urge to move the legs. It's often accompanied by unpleasant sensations, shown in the bottom right, so often a crawling or itching sensation. Rest or inactivity increases the urge to move, and getting up and moving improves the symptoms. And the symptoms usually get worse in the evening. And in a pilot study that we did at Mass General, we found that 40% of adults with restless leg syndrome had RLS, 40% of adults with ALD had RLS, and females were more commonly affected than males. So now I'm going to turn to the current study I've been working on with the help of Elizabeth De La Rosa and Yetta Lee, one of our neurology residents. And in the study, we performed a retrospective chart review focused on evaluating the female disease burden in ALD, age of symptom onset, any symptom management strategies used, and other relevant experiences as a woman with ALD. So we looked at medical records of every woman with ALD who's been seen in Dr. Eichler's leukodystrophy clinic at MGH dating back to 2007. And we identified 79 female patients with ALD, and the chart on the right shows the age distribution of these patients. So patients range from 28 to 86 years, with a median around 50 years of age, and women tend to start presenting to clinic around 30 years of age. So we found that around 90% of patients had neurologic abnormalities. These were the most common signs and symptoms that our female patients presented with. So the most common exam finding was impaired sensation in the lower extremities, and the most common symptoms that patients reported were pain or discomfort, bladder dysfunction, and gait abnormality or walking difficulty. So this is a representation of how disease severity changes over time. So we calculated how many of those 15 signs and symptoms each patient presented with, and then looked at the average number of signs and symptoms in each age group. So this data shows how symptom presentation doesn't only increase with age, but also that the degree of symptom burden increases with age as well. And one of the things that we're interested in looking more into is the onset of each individual sign and symptom. It is difficult to assess retrospectively due to limited data, and also many women, when they initially present to our clinic, already have at least one sign or symptom, particularly impaired sensation or hyperreflexia. So over time, as we see more asymptomatic patients, hopefully we can learn a little bit more about this. We also looked at which symptoms patients reported that they first presented with, and the three most common symptoms were pain, gait and walking difficulty, and urinary or bowel dysfunction. So I also want to highlight some other experiences that impact the lives of women with ALD. So first, more than half of the women in our clinic had a history of falling. So women with ALD are at a higher risk of falling due to walking difficulty and imbalance. Falls often lead to fractures and other injuries such as sprains or dislocations. We also found that 28% of women had low bone mineral density, so that also increases the risk of fractures. And women with ALD often also experience sleep disturbances and depression and or anxiety. So both of those were in around 60% of women in our cohort. And these symptoms are likely interrelated. So neurological symptoms such as pain or muscle spasms likely contribute to insomnia, and one's own physical symptoms also likely contributes to anxiety or depression. And depression and anxiety is often also caused by or exacerbated by a diagnosis or disease in a family member, especially in a child. So this shows all of the different types of oral medications that women in our cohort had tried to manage their symptoms. So the most common type of medication was pain meds in about 2/3 of patients. So aside from oral medications, patients have also tried a variety of other interventions for symptom management, including surgeries, steroid injections for pain, and Botox injections for spasticity. Over 1/3 of women also use some sort of walking aid, most commonly unilateral aid. And a knowledge gap that we're very interested in learning more about is what types of interventions and management strategies are most effective for women with ALD. So through looking through medical charts, I've seen a lot of patients who have tried a medication that hasn't been effective or has caused side effects that just aren't worth it for the patient. And we heard yesterday from a symptomatic patient that, Botox actually worsened her symptoms. And I think collecting this information is key next step to understand how to best manage these symptoms. So in the study, we also gathered diagnostic information and age of onset for adult male patients for comparison purposes. So this is a survival curve with the y-axis showing the proportion of patients with symptoms at that given time, and then the x-axis showing age. So the blue line shows the symptom course in men, and the red line shows the symptom course in women. So here we see that women present with symptoms approximately 10 years later than men, with an average age of onset around 26 years in men and 37 years in women. And this just helps us kind of distinguish between the experience living with ALD for men and women. So another very important thing to highlight is the high rates of misdiagnosis of females with ALD. So of our 79 patients, at least 21 faced delays or challenges in obtaining an ALD diagnosis. And of those 21, 16 were actually given an incorrect diagnosis, most commonly MS. Another data point that we collected for both men and women is what led to their diagnosis. So in other words, did they seek care for symptoms they were experiencing and were subsequently diagnosed, or were they tested for the disease due to a known family history or diagnosis of a family member? And we found that men were more likely to be diagnosed by symptom presentation, but this was very rare in women, with only 16% being diagnosed due to symptom presentation, despite 2/3 of women experiencing symptoms prior to diagnosis. And the majority of women were diagnosed due to a family member being diagnosed, typically in a male relative. I should also acknowledge that the symptom presentation in men also does include symptoms of adrenal insufficiency, so it's not surprising that this proportion is higher in men, but it's still an important thing to just acknowledge. And another knowledge gap is just what other barriers are encountered. So, we heard from a woman yesterday how genetic testing was a very difficult process and can also lead to delays. And there's likely other challenges faced, with financial barriers and insurance barriers and the lack of experts. So it is hard to assess this retrospectively. So we're hopefully going to be able to talk to patients prospectively and learn more about different barriers and challenges faced. So just a few takeaways I want to highlight before talking about some of our upcoming studies. So first, over 90% of women in our cohort do experience symptoms, most commonly pain, urinary dysfunction, and walking difficulty. And beyond neurological symptoms, there are high rates of anxiety, depression, and sleep disturbances. And these symptoms are severe enough to require medications or other interventions for management or symptom relief. Symptom onset is approximately 10 years later in women than in men, but it is by no means simply a milder form of the male disease, as it has been described in the past. And 1 in 5 women are misdiagnosed, and the diagnosis in women is rarely made without an affected male relative being diagnosed first. And just one thing I should mention as a limitation is that these numbers do likely overrepresent the symptomatic patients, since our cohort consisted of patients who had been seen in Dr. Eichler's leukodystrophy clinic, similar to a lot of other research in ALD. So just shifting gears to talk about status of clinical trials in women with ALD. So a major unmet need for women in ALD is the lack of access to clinical trials. I know I'm probably preaching to the choir, so I've heard firsthand from patients how disempowering this can be. And so I just wanted to provide a visual on this. And I looked on clinicaltrials.gov at all of the previous, current, and upcoming research studies for adult patients with ALD, specifically for spinal cord manifestations, so not looking at trials for cerebral ALD. I found 16 total interventional trials, and of the 13 clinical trials with a pharmacologic intervention, 9 were limited to males only. And that being said, I do want to acknowledge that there are challenges to implementing clinical trials in women. So for one thing, like the disease progression is quite slow, which makes it difficult to show treatment efficacy without extending a clinical trial for 10 or so years, which of course causes financial challenges and participant retention challenges. The disease is also different in women than it is in men, so it might require a different treatment approach. So this isn't simply just the result of women only being seen as carriers. It's definitely more complicated than that, but it is still an unmet need that I wanted to highlight. And that being said, we are in the process of launching a joint study with a group in Amsterdam, which will be focused on leg symptoms in women with ALD. So this is a 2-phase study. Phase 1 will be observational and will focus on identifying the prevalence of leg-related symptoms in women with ALD. And we're looking to recruit 100 women across the 2 sites for Phase 1. Phase 2 will be an interventional trial, and we'll be focusing on treating symptoms of restless leg syndrome using pramipexole, which is an FDA-approved treatment for RLS. And we'll be recruiting 24 patients across the 2 sites from Phase 1 of the study. And we'll be doing this using a crossover design, meaning that patients will undergo a treatment course using pramipexole and also a course of placebo, but the order in which they receive those 2 treatments will be randomly assigned. So just to give a quick overview of the 2 phases. So in Phase 1, we're recruiting adult women with ALD, so women 18 years and older, both asymptomatic and symptomatic women. The goal is to assess the prevalence of leg-related symptoms associated with ALD, so restless leg syndrome, walking difficulty, spasticity, neuropathy, also looking at depression and anxiety. And in the study, there will be up to 3 remote interviews with the study team. So this will include an ALD expert, an RLS expert, and the study coordinators. And it will also involve completion of surveys. So because it's remote, it wouldn't involve any traveling to either of the sites. And to be included in the study, this will be posted on LeuConnect. I should have mentioned this is going to be funded by the European Leukodystrophy Association, and LeuConnect is their patient portal. So if you're already part of that, you can apply through LeuConnect. You can also register on LeuConnect. And we're also going to be recruiting in our clinic at MGH as well as in Amsterdam. And you can also contact us. I put Elizabeth and my email addresses up here. You can also come talk to us if you have any questions or want to talk more about it. And then in phase 2, we're going to be including a subset of patients who participated in phase 1, women ages 18 to 75 years with moderate to severe restless leg syndrome. We also have some other eligibility criteria that will have to be met. And as I mentioned before, this will include treatment course with pramipexole as well as with placebo in that crossover design, 8-week treatment course for each. And it'll involve some neurological examinations, walking tests, sleep measures, and completion of surveys. One of the sleep measures we're doing is polysomnography, which is a test to measure sleep and different sleep variables and sleep-related leg movements. And the goal is to determine if treatment with pramipexole will significantly reduce RLS symptoms. So just to kind of highlight some exciting things about the progress being done in the field. So first off, there is an increasing awareness that ALD can be a devastating disease for women. And there are many people who do genuinely care about this and are working hard to drive that progress in the field. The implementation of newborn screening will allow us to identify more women with ALD, particularly asymptomatic women, which will allow us to have a better understanding of, the full picture of the disease. And we've already seen this impact where 12 of the women in our cohort actually were discovered to have ALD because of their child being diagnosed on newborn screening. There is more attention that the impact of ALD of the impact of ALD beyond neurological symptoms, so that is the mental and emotional impacts of the disease. And there are exciting trials coming up. I also wanted to briefly mention a trial that the group in Germany is doing, and that is evaluating the efficacy of a multidisciplinary lifestyle intervention for women with ALD. So I think that trial sounds awesome and excited to hear more about the results. So thank you so much to all of our funders, groups that we work with, advocacy groups, and of course our patients who've all had such an impact in increasing awareness about females with ALD. Happy to answer any questions.
Thank you, Dean. Thank you so much. I'm sure we're going to have a lot of questions. So let's start here, because you're the first person I saw. Here you go, Tim.
Thank you, Greg. Wanted to know if there was any correlation. You said the average onset was 37 for women. Is there any correlation to the father's onset of their symptoms when they were diagnosed to when the women's?
That's
I
not
have
something
3
that we
daughters.
looked at. That is very interesting, though. So we haven't looked at that.
You haven't? Okay.
Another question here from Dr. Lund.
So I'll just be devil's advocate. How do you know any of this has anything to do with ALD?
I guess we don't. I mean, there's, of course, high prevalence, but I think that is a good point to make because some of these things like restless leg syndrome is more prevalent in women than it is in men. So it is important to acknowledge that, there might be other factors, same with the urinary symptoms, that it might not only be due to ALD. So it is definitely hard to distinguish. And I guess this isn't by any means saying this is definitely due to ALD, but it still exists. So
How would you figure it out?
fluorine.
You start by studying it, right? And looking at background prevalence across different age groups and gender is hugely important. So we do this with larger groups, movement disorders, where we were starting to study different symptoms, particularly dystonia compared to background overall population, and restless leg syndrome, same thing. And we do find significantly higher numbers. Now, is that due to a selection bias because people are coming to us who are having symptoms? All of these things are valid, but it still remains a topic that we need to delve into, studying the asymptomatic patient population, all the things that Stefan mentioned before, equally relevant here. So I think we're just in a phase of mapping things out, and etiology is still something that we have to figure out over time.
Right, we have another question. Get the mic on, Dean.
Hey, so very nice talk first. So about the RLS that you mentioned, so the pramipexole is kind of a last line treatment because of the dopaminergic effect that it has. So I want to know if the first line treatments like gabapentin, are they used before, and are they effective or no?
Do you want to address that, Florian?
Okay, we have another question. Amber?
So,
oh, I'm sorry.
Sorry, I'll take this one
Oh.
quickly, and we can talk offline as well. But in the RLS field, people don't see pramipexole as a last-line treatment. The Neurontin, addresses more of neuropathic pain and can be effective in RLS as well. But I see pramipexole as sort of a very specific neurotransmitter impact, and you can very quickly assess whether it's effective or not. So I think there's, compared to the slow ramp up of Neurontin, definitely a benefit here.
Yeah, a similar question to Tim, but the reverse. So when you see the mothers, can you then also study their sons so that if somebody sees that their mother doesn't have symptoms and she's 60, does that give them a reason to believe they may have delayed AMN? I mean, the boys may have delayed AMN, because that would be also relevant.
Yeah, absolutely. We can definitely look into that.
Okay.
That's not the experience we've had, so I've not seen a correlation. It's not published, but I've seen sick moms with very good looking sons, and vice versa. So, just want to say I have not seen a correlation clinically, but it's not published, but Yeah. So we've seen very, very affected women with very mildly affected sons, and vice versa. So.
We have another question over here, Kelly, and then we'll get to that.
Okay, not to shame the good doctor, Dr. Lund. He sounds exactly like all the doctors that I'm seeing. I have to go to one of the specialists. But I've had some falls, I've had some short-term memory issues, and some other things. And they all say, how do you know? I mean, I tell them my history with my, that I'm a carrier and I have 2 boys with ALD, cerebral ALD. And, oh, it's your age. It's probably menopause and all these symptoms. And it's so frustrating because, my gut instincts tell me this is what it is. And they're trying to tell me, no, this is all, it can all be explained away. I mean, the falling, well, maybe you weren't paying attention kind of thing. I would have a few years ago said that, but not now. Because I know I was paying attention. I'm a lot slower to things. But memory issues bother me the most. But anyway, Dr. Lund, you're a wonderful doctor. But exactly, the devil's advocate, that's exactly how they sound to some of us patients if we don't see, go to Baltimore or go to Massachusetts, which I will be going now.
And I do have to say, I looked a little bit into that in doing my research, and I did find that women are more likely than men for their symptoms to be minimized by physicians and told that they are imagining them or that they're probably due to something else. So, yeah, exactly, yeah.
We have one last question here from Oh, I'm sorry. We have two. Taylor Kane, go ahead
Hi.
first.
Yeah, mine is kind of also on this topic. I'm curious, this is all kind of sort of for the Amsterdam team. I'm curious if you feel that like those plasma C26 lyso-PC levels, yesterday you were saying that in your initial research it seems that those are correlated to symptom severity. Could that potentially one day help us understand if these symptoms in women are actually related to ALD or if they're like something else?
Well, thank you for that very complicated question. No, no, you're absolutely right. Maybe it's a factor, but in women, of course, the X inactivation is also a very complicating factor. But definitely something to look into for the future. Yeah, and they're related, of course. Yeah, yeah.
Sorry, I keep hearing that being able to detect progression might be a 10-year odyssey. But I just wanted to ask Dr. Smith-Fine and Keller to talk a little bit about the power analysis and sample size and duration of observation from your wearables certainly shortens that to a much more realistic phase. If you could just comment on that.
So we're getting a tiny bit off topic and a little bit behind.
All right, in the interest of... Oh, we have one more? Great, one more question maybe?
No, it's the answer. It's
Oh,
the
I'm
answer
sorry.
from, yeah.
So I guess that from the LO study, the sway data did show that we found a significant change in women's body sway over 2 years when we looked at the 4 different conditions, and that the changes were significant enough that we didn't need as large of a study population to study an intervention. So I'm afraid I don't remember the exact numbers. So it was around 40 for women to see change that was estimated would be needed in a placebo-controlled trial for women, and then about twice as many for men, and a little bit, and somewhere in the middle for both. So.
Can I know we are running behind, but I do want to comment on this as well. And I think that the challenge we're facing here is that the world is not black and white. And there's a spectrum in every condition. And so it is in females with ALD. And but by the way, argue that we should say females with ALD rather than women with ALD, just to be more compassionate with the times. But, there are symptoms that are clearly related to myelopathy. And there are symptoms that are common in general population with aging. And then there are symptoms that, are highly unlikely to be related to anything with ALD. And it doesn't really matter. We can say, okay, if you have myelopathy, clearly that's AMN, or that's clearly ALD. If you have symptoms that are neurological, well, we should study on the academic side, like it's happening right now, but we shouldn't ignore them. We should still treat them. I mean, just because, you have ALD doesn't mean we can't treat back pain. It doesn't mean we can't treat arthritis. We can't treat restless leg syndrome or dysphonia, whatever. These things that we're not 100% sure whether they are or are not related. So I think this sort of antagonizing thing doesn't help with the research and doesn't help with the actual clinical care. My approach would be if you go and see a doctor and the doctor says, well, this may be ALD, it's like, okay, fine, but still help me. I still can't sleep. I still have back pain, right? It doesn't really matter. Right? I think that's the problem that we face, and this constant sort of going back and forth because we're being dismissed, we're not being dismissed. Well, if it's a myelopathy, that might be the best measure for assessment of a clinical trial, but we don't want to ignore all these other things, and we don't want to sort of say, okay, now that I can blame this on ALD, I'm good, because you still have the pain. That doesn't help neither, right? So I think either way, we need to take the symptoms seriously, regardless whether they are or not related to ALD. And I think that would be the approach that I would do to my physician when I see them.
Thank you so much, Natalie. Let's give her one more round of applause.